Welcome everybody. It's Bronwyn Edwards here from Roses in the Ocean, and with me is Carrie Lumbey. We'll just wait a few moments. I can see more people joining the webinar, so we'll just give everyone a minute to come into the space. All right, well, welcome everybody to the Brisbane North PHN co-design feedback loop number 1 for the Safe Space Hubs. Really great to be with you today. Firstly, I'd like to acknowledge the traditional owners of the lands on which we're all meeting today and pay our respects to ancestors and elders past, present and emerging. I'd also like to acknowledge people with a lived experience of suicide. So thank you to all those people who have joined this co-design process and brought their incredible insights and wisdom from their lived experience of suicide. We'd like to remember all those within the communities in which these safe space hubs will be established. And we also acknowledge the impact that suicide has on others through their line of work. So to orientate you to where we are in the process, at the moment, we have enjoyed lived experience focus group sessions, and so small groups of people with lived experience of suicide coming together. We've also had all of those people with lived experience come together in a larger group session. In parallel to that, we've also had small focus groups with health professionals and other stakeholders, and also a group session with those people. So all of that information has been written up, collated, themed, and it's what we're going to share with you today in this first feedback loop. So today's webinar is live. It is also being recorded and will be available to be watched again, but really importantly, be available to share broadly with other stakeholders, other people within the communities of where these safe hubs are going to be. There'll also be an online survey, and we really encourage you all, those of you who've been part of the co-design process so far, you may very well have thought of other things, had some additional ideas. Please contribute to that survey. And for those of you who have not been part of the process so far, this is your opportunity to bring your ideas and thoughts into the process so far. All right, so just a bit of a reminder to set once again the context for those who are new to the process. Here are some guidance and some principles that we've been provided by the Brisbane North PHN. So in terms of days and times of the service, the sites will operate outside of normal business hours, and the Primary Health Network seeks to understand what days and times the service should operate and why. With regards to location, the Brisbane North PHN currently hosts 3 mental health hubs. There's the Stride Hub at Caboolture, Nemai's Living and Learning Centre in Strathpine, and Communify's Recovery and Discovery Centre in Bardon. The proposal is to locate the safe spaces at the hub locations, and this co-design will seek feedback on these locations. In terms of guiding principles, the safe space hubs are a peer-led alternative to hospital emergency departments for those experiencing emotional distress and suicidal crisis. The safe space hubs will adopt appropriate use of peer workforces, offer clinical support, including on-call supports to ensure a warm and welcoming space and service where guests are supported. And the Safe Space Hub will take a no wrong door approach and seek to provide connections to services and the community. So I'm just going to hand over to Carrie now, who's going to walk you through what we've heard from everybody with regards to feelings and emotions, needs and values.
Thanks, Bronnie. So I'm just going to walk you through now, first of all, what we heard from people with lived experience in terms of the feelings and emotions associated with each of what we were calling the critical touch points in accessing help when in distress and crisis across the ED process or supporting someone to do so. We also had the carer perspective in the room. What I'd encourage you to do, I don't want to sort of labour every single point here, but please, because this is recorded, you can go and look at the recording and press pause and dig into the detail. These slides will also be embedded in the survey, so you can take time to have a look at them then. So in terms of those touch points, so the initial point of finding help through an ED process, so reaching out for help or supporting someone, perhaps you are looking to connect them with help. The feelings associated with that for people with lived experience locally are lost, frustrated, disheartened, angry, upset, panicked, fear, disempowered, distressed, anxious, guilty, and helpless. So a couple of quotes to animate those feelings. Someone said that my head knows I've got to go, but my heart doesn't want to because I know what the outcome will be. Another person says, everyone says present, but what's the use presenting to a situation that's going to make you feel worse? It's terrible. And then someone from a caring perspective said, I was absolutely distressed because I felt guilt that I had to escalate it to an ED, knowing what I had gone through there. And then in terms of the arrival and an initial assessment phase, the feelings associated with that phase were scared, anger, confronted, guilty, stressed, annoyed, confused, demoralized, shame, hopeless, and desperate. And someone says that they were angry at the system not being able to help me when everything about the system is telling me to get help, and that the intake process is stressful. There's no time for that human touch and having someone to greet you. And then from a caring perspective, we heard someone say annoyed because he had to tell his story 10 times to all these different people. And then at the waiting stage, which we know is a critical period, and people might wait at different points across their help-seeking process. So the feelings there were angry, upset, lonely, anxious, helpless, distressed, and agitated. Someone said, I've always felt very isolated waiting there. It was like a reinforcement to me that nobody cares. And then from a caring perspective, the waiting added to my distress. The longer I waited, the more anxious I got. And then the treatment phase, not everyone gets treatment or feels they've received treatment in the traditional sense, but for those that receive some form of treatment, whether that's in ED or perhaps in part of an inpatient admission, the feelings associated there were helpless, hopeless, stressed, scared, sad, frustrated, isolated, emotionally exhausted, and angry. And someone said that they felt helpless and small, like a child, and I couldn't speak on my own behalf. Someone else said, could someone just sit with me, sit beside me, and stop trying to test me and assess me and just listen or just be there? Frustration kept bubbling up. And then from a caring perspective, someone said that she's treated like an inmate rather than a patient. It's hard to see her in that environment and hear people speak to her like that. And then in terms of the leaving touch point across the ED process, which we know is also a very critical point in time for people who have been through suicidal crisis, through extreme emotional distress. The feelings associated there are angry, desperate, anxious, humiliated, dismissed, hopeless, frustrated, drained, scared, lost, isolated, exhausted, alone, and deflated. Someone said that I told them I'm not okay to leave, but was pushed out the door. I cried the whole weekend. It was so humiliating. Another person said simply, I felt helpless and hopeless. I had nowhere to go. And then from a caring perspective, it put a burden on me that they shouldn't have expected from me. I was often expected to pick up the pieces and do too much. We also know that it's very important to capture the feelings and emotions associated with choosing not to go to ED for people. Sometimes that's because people have had unhelpful experiences in the past and no longer would seek help through that process. So the feelings there were desperate, lonely, frustrated, abandoned, isolated, and angry. and someone said, if I had a physical emergency, I would go to the hospital, but if I was in suicidal crisis, I wouldn't. I felt like the judgment, the stigma, the shame, the discrimination, I would not get the care I deserve. And from a caring perspective, she refuses to go to ED because of feeling judged, having to go in with all those people, and someone might know her, having to sit in the middle of everyone. Then another person said, as a carer, I used to get very angry about the failure of the medical model for a lot of people in distress. And then we explored, we know that that feelings, there tends to be unmet needs sitting behind strong, particularly negative emotions. So we explored with the lived experience cohort, what were the unmet needs there, and we've grouped them into emotional, practical, and then information needs. So in terms of those touch points, at the finding point, emotional was support and reassurance, someone to calm you down, connection, to feel emotionally safe, to be taken seriously, empathy and compassion, validation, no judgment, physical safety, alternatives to the conventional medical model, something accessible and face-to-face, and information, guidance, someone to walk through what will happen, and up-to-date information about options available. In terms of the arriving phase, a warm greeting with compassion and sincerity, someone with a lived experience to connect with, to be treated like an individual, empathy, to be seen quickly, information about where to go, even where to park, a quiet space that feels safe and warm, privacy, clarity and good communication, consistency, knowing what to expect. We heard that a lot, people feeling like they were quite confused and unsure of the process. And then waiting, it was reassurance, someone checking in, the option to have a carer there, support for carers, power to create circumstances that work for you, options such as a quiet place to sit, having someone sit with you, family to be there, people who understand, physical safety, a cup of tea and a snack, a comfortable space, music and other distractions, a homely, familiar environment rather than, you know, people talked about that cold clinical environment, a place to decompress, and again, where carers are welcome. So it's coming out of this local co-design, the importance of being able to have support, adequate support for carers, information to know what's going on and to know how long the wait will be. In terms of the treatment phase, again, to feel acknowledged and heard, to be taken seriously. You can see very strongly coming through empathy again as an important need, warmth, feeling of welcoming, a collaborative process that is empowering to the individual, a non-judgmental approach, alternatives to medical intervention. So it came up actually in both groups, that idea of grounding techniques, for example, meditation, a physically safe environment, communication with carers through this phase as well, strategies for how carers can support their loved ones, written information about next steps, up-to-date information, information about long-term options available for the person and their carers. And then at the leaving phase, feeling like you're not alone and someone is looking out for you, to feel supported. Again, collaborative decision-making, feeling like there's a safety net you can fall back on, timely follow-up support, including phone calls and home visits, practical support to get home, an easily accessible point of contact to come back to if needed, communication with carers again, so everyone's on the same page, help navigating follow-up support. So not just follow-up support, but we heard people really need help navigating that, clear communication of next steps, and again, up-to-date information about follow-up, available support options, both for the person and for carers. We also got the lived experience participants to talk about, to get us to think about what are the values that really would guide best care for them, so that their experience, not just of the supports, but their experiences of supports would really meet their needs. And these are the ones that locally that the lived experience participants came up with. So they're the values of acceptance, inclusiveness, accessibility, openness, non-clinical, individuality, diversity, authenticity, connection, self-determination, transparency, dignity, safety, compassion, community, and equity. And then in terms of the health professionals, and you'll start to see a lot of the feelings. This is what often happens in co-design processes, that the health professionals' feelings of trying to provide the very best care for people while in crisis. Often there's a lot of common themes between the lived experience participants and then the health professionals. And I'll read you the feelings and then just one or two of the quotes. And as I said, you can look at these in your own time. So in terms of that reaching out for help phase, supporting someone through that phase, overwhelmed, stressed, disappointed, concerned, frustrated, confused, sad, anxious, and relief. And a health professional said, I'm not confident in the process, so to suggest to people this is where we can get the support. I'm subconsciously thinking, I'm not sure what the outcome of this will be. They'll go through the process of ED and triage and will generally be dismissed. And someone else said, I want them to be in a position where they don't have to deal with the fear of going to hospital. Then in terms of the arrival and initial assessment phase for the health professionals that are in this co-design, where they have been part of that phase. Of course, not all health professionals are supporting people through every touch point. The feelings associated with this phase was disappointed, anxious, concerned, nervous, frustrated, helpless, powerless, sad, drained, and tired. And a health professional said that it was disappointing that people are not taken seriously. And someone else said, I feel infuriated, frustrated on their behalf. I feel embarrassed for the service. And then during that waiting period, health professionals that experience providing support during that phase for people, the feelings associated for them were sad, exhausted, stressed, frustrated, empathy towards the people in crisis, and a sense of failure that they were letting the person down. And then why? Someone told us that it's a judging and stigmatising environment. They're put off into the corner and have to wait. They feel very judged. It makes me feel quite sad. Mental health isn't given the same weight as physical health. Then in the terms of the treatment phase, for those health professionals that have experience supporting people at this phase, the feelings were exhausted, disappointed, helpless, worried, frustrated, and sad. And someone said that I just know it's not going to be a great outcome for them, and it feels really disappointing, like a level of helplessness when they come back to you, and their motivation to contact the system again is going to be zero. And then in terms of that critical period of leaving after seeking help or supporting someone to seek help while in crisis, the feelings there are disappointed, worried, concerned, stressed, distressed, but also someone spoke of hope. And that person said, I'm hopeful that they'll have interacted with just one helpful person. But alternatively, someone said, it feels like we're backtracking. We need to rebuild the trust. It takes months to rebuild trust with clients. We also explore with health professionals what they feel that they would need to be confident and comfortable promoting and supporting a safe space hub in their local region. And we've grouped them here broadly into sort of key features of the service. So inward connections, health professionals say that they would like to see good community awareness of the service, clear communication between service and safe space, information about opening hours and process, consistent data collection processes, a pathway from ED into safe space and vice versa, inward referral pathways or connections for QPS and QAS. In terms of the service model, again, there was from the health professionals the idea that there should be some role in supporting carers. The environment should be normalising the crisis to minimise feelings of shame, and an outreach component. In terms of the accessibility, no age restrictions, the ability to visit the site to understand what we were supporting. So health professionals wanting to be able to come into the space, that it's non-discriminatory in terms of any policy, and easy to access for a health professional if needed when the space is up and running. In terms of staffing and workforce development, highly skilled and capable peer workers, ability to help, able to help someone manage distress, but also can just sit and listen. So that idea that there didn't need to be a lot of doing always, but the capacity to hold space was something we heard. Staff with DBT training was suggested, accepting attitudes and no stigma, workers having access to good supervision, support workers with a trauma-informed practice background, and then processes in place for staff safety. In terms of the physical environment, an inviting, relaxing and non-clinical environment, comfortable seating and distractions, not overcrowded, people having access to private spaces. So we heard this idea of there should be a flexibility of the space, the physical space, off-site from hospital, and also an area for kids if someone comes with kids. We also, in this local co-design, we heard very clearly from both people with lived experience and health professionals around that there will be some unique cultural barriers to accessing services. There have been with traditional services, and really that people are wanting these new safe spaces to be able to overcome those barriers. So we've just captured them here. So recognising that people who identify as LGBTIQA+, and also people who are considered to have come from diverse cultural backgrounds. So there was a real recognition these people are already disproportionately impacted by stigma and discrimination, and that becomes compounded through access to services quite often. So from a lived experience perspective, people said that they really want to see that data collection includes pronouns, preferred names and other gender options. And we heard from someone who said it's distressing when you're already in a vulnerable place. It just keeps adding on and on and on to that when hospital staff don't have a good understanding of what being transgender means. And then also someone saying if someone is presenting to ED having thoughts of suicide, the last thing they need is someone who misgenders them or refuses to use the name they use in their pronouns. And then health professionals talked about a lack of communication from ED once clients go there, particularly when someone is in a community-based multicultural service, for example, and then when they're in the ED, there's not a sort of, they're not speaking to each other, those different services, and that clients need to be able to provide cultural context to their story, but ED doesn't have time to listen. And then that means that, and there's a quote here from a cultural context, clients need to tell you the context for their problems, but practitioners in ED only have the time and only able to hear the problem. And that ED is binary and not safe for gender diverse individuals, that trans and gender diverse individuals often have to educate people when accessing services. So I read those quotes before, and we certainly heard that people can be in crisis, they're already subject to stigma and discrimination, and then they're in that situation then having to do a gentle education process with the people that are there that should be providing the care. And then also the mainstream system doesn't recognise the importance of cultural organisations which can provide support. So that idea that there are these community-based organisations and they're not speaking to each other at that point. So clients from a cultural background face stigma and don't always want to say what's going on. You need to engage with the family, but in ED they don't. So just missing that bit in terms of a collaborative approach to supporting people from diverse cultural backgrounds. So Bronnie, I'll hand over to you to take people through the blue sky dreaming, the really exciting part of a local co-design process now. It's about how the safe space hubs will meet these needs that have been identified.
Lovely, thanks so much, Carrie. All right, so what we'll see here in the far left-hand column, we've got identified needs from people with a lived experience of suicide. So this is super important because it's about meeting the needs of the people who will use the Safe Spaces Hub. Then in the middle column, we have the blue sky dreaming from the groups of people with lived experience. And then health professionals, we're looking at where there's any alignment and if there's any divergence and areas for more discussion in future sessions. So just a note on the blue sky dreaming as well, everyone who's been part of this co-design process has explored the guidelines and the principles that we shared with you right at the beginning, but everyone's been really encouraged to blue sky dream, as well as holding on to and managing expectations around what is possible at the moment. But because of that, that genuine co-design that has that iterative approach to it, it's super important that we actually gather the blue sky dreaming. And so that as the services unfold and more opportunities may become available, then you can always come back to this co-design as a foundation, and then obviously have that ongoing co-design and start bringing guests into that process as well to continuously improve what's being offered. So when we look at needs and how to meet them in relation to the location, identified needs were physical safety, genuine alternatives to ED, and that this was discussed in the group session where location was explored in a lot more detail, which is why there's not a lot in that identified needs column, because the greater part of that discussion around location happened in the blue sky dreaming space. So people with lived experience of suicide are saying that they're looking for a space that is off-site from the hospital and away from ED, close to the hospital for ease of access if needed, separate from any clinical environment, not attached to the existing mental health hubs. It's in a quiet area away from busy streets, near a park or a river, cafes, and close to public transport. When we look at our conversations with the health professionals, there's absolute alignment in terms of the space being off-site from hospital, close to public transport, a new location that can be fit out per co-design findings. So that's all in alignment with what the people with lived experience are asking for. The comments there that are in orange indicate that we need to have some more discussion about it. So close to the hospital for ease of access and close to ED for ease of access, both of those are saying the same thing. The reason that's in orange is because some of the safe space hubs are not actually close to the hospital. And then not attached to the existing mental health hubs. We've marked that orange for more discussion. We're very aware that the proposal from the primary health network is to use the existing spaces of the existing mental health hubs, but that we were to seek feedback on that through the co-design process. So it's an area that requires more discussion. Thanks, Carrie. So when we look at inward connections, you'll see everything that has been discussed by people with lived experience as well as health professionals in alignment. So in terms of identified needs, it was to be welcoming, non-judgmental, that you can just walk straight in, not having to make an appointment. But once again, this area was discussed in a lot more detail in the blue sky dreaming space. So people with lived experience are looking for strong relationships with other services, both in and out. So those connections into the safe space and then connections to support beyond the safe space. They've suggested a memorandum of understanding with the Queensland Ambulance Service. And we've definitely heard from QAS their absolute willingness and really quite positive outlook about being able to take people directly to a safe space and not have to take them to ED. Building up a community for guests and staff to provide a network of people with lived experience to coordinate, help and support both in and out of the safe space. That it's easy to access, not a lot of steps to go through, open and welcoming for everyone, and that families and carers can call ahead of coming in with someone if they want to. From the health professional conversations, they too also are really wanting partnerships with services like the Queensland Ambulance Service, pathways to the safe space from the emergency department, really wanting GPs to be aware of the safe space so that they can advocate for it as an option for their clients, and that the Queensland Police Service should be aware of the safe spaces also as an alternative to ED, and that they are to be easy to access with not many steps to go through as well, not sort of having to jump through hoops in order to be able to come. Thank you, Carrie. All right, so then we looked at, right, what about connections out from the safe space to further support and partnerships? The identified needs were that there would be timely follow-up support, practical support to get home, an easily accessible point of contact to come back if needed, up-to-date information about follow-up, available support options for both the person and carers, some help navigating follow-up support, clear communications of the next steps, and feeling like there's a safety net that you can fall back on. You'll recognise these from the work Carrie's just shared with you. So in the blue sky dreaming from the people with lived experience, really looking for connections to other services for people who have other needs. So housing support, social workers, clinical supports, a range of options for external and follow-up support. Suicide prevention peer workers who can advocate and navigate with the person. Ongoing support to help people connect with other services. So person given the choice in how much support that they need and want. And from the health professionals, we heard connection to other services such as housing, clear pathways available for Safe Spaces staff to be aware of other services. So lots of discussion around the importance of really good, strong community relationships and connection, so that the peer workers in the space absolutely have a great knowledge of what's available, have relationships with those people. They know exactly what's being offered and their capacity to help and be able to connect people. Authentic follow-up, but only if the person wants it. Options for external support if the person wants it. So a lot of real valuing that self-determination for guests of the safe space. And there was one comment here, is that safe space primary purpose is capacity building through coaching and psychoeducation. So that, once again, it's in orange, needing to be explored a bit more in terms of how that fits with the model and the needs and wants of people with lived experience. Thank you, Carrie. Was there one before? Did we skip one then, or? Oh no, that's good, thank you. Okay, service model. So identified needs from people with lived experience. They spoke about needing support, reassurance, connection, to be taken seriously and seen quickly, validation, no judgment, guidance, someone to walk through, you know, what will happen now, alternatives to the conventional medical model, support for carers, power to create circumstances that work for you, such as options as a quiet place to sit, having someone sit with you, family to be there, etc. A collaborative process that's empowering, and strategies for how carers can support their loved one. Information about long-term options and available for the person and carers. So once again, lots of alignment here, lots of green. Group activities at set times that people can attend to feel safe and welcome, even when not in crisis. Activities and things to do, including music and games, choice in what information you want to share, lots of resources available for those who want to use them, empowerment through knowledge of resources and choice, carers, family, friends, all welcome and can get their own support, and that it's actually okay to not be okay while maintaining the safety of workers and guests. And no one size fits all approach, welcoming and inclusive for all cultures and trauma informed. The health professionals talked about activities and games and art, those sorts of things. Again, welcoming for carers is a really strong theme in these three regions around wanting carers support. Assistance with service navigation, social connectedness is a strong purpose, support for the person to link in with other community supports and services and follow up to ensure that the need is actually met. So there's, once again, there's been conversation from all groups around making sure that that follow-up's done and make sure that the help was actually helpful for that person. And if it wasn't, to be able to connect back in with them and find, you know, another option of support. And that choice in what information that people want to share. So all of that was in alignment. Just a couple of things for further discussion at future sessions. Just making sure that not duplicating what other services provide. So no group activities if another service offers this. So just some discussion around the purpose of having group activities in the safe space, even if they are available somewhere else. So there's a little bit of additional conversation to be had there. And the option to access clinical support in the space. So once again, that comes down to staffing and the actual service model when there's been conversation about it being non-clinical and peer workers only in the space. Thanks, Carrie. Okay, so to staffing and workforce, the lived experience identified needs are that they receive a warm greeting with compassion and sincerity, someone with a lived experience of suicide to connect with, to be treated like an individual with empathy, compassion and warmth. Clarity and good communication. Consistency, so they know what to expect when they come to, there's a couple of layers to this. So consistency, knowing what to expect when they come back to the safe space, but also if they happen to come to the safe space, one safe space hub, and then another time they wish to visit another of the safe space hubs, there is some consistency, not expecting them to be exactly the same, but they do generally know what to expect. People who understand, to feel acknowledged and heard, to be taken seriously, feeling of welcoming, feeling like you're not alone and that someone is looking out for you, someone to help calm you down, and to feel supported and emotionally safe. So as you can see, full alignment here. So compassionate and empathetic, diversity in gender, cultural background, LGBTIQ, personal lived experience as well. So diversity in the peer workers. So peer workers with a lived experience of suicide, that there's no assumptions made about people's identity, that peer matching is available through having that diversity in a pool of suicide prevention peer workers. So you've got a choice in who you speak with. And staff are trained to recognise and respond to other needs and in de-escalation. And a no zero tolerance policy. Staff are trained to work with people who may be emotionally dysregulated in crisis. And the health professionals spoke of diversity in the peer workers, again, compassion and empathy, support and supervision for the peer workers, no zero tolerance policies, but protocols, training and physical environment to ensure staff are safe. Basic skills in grounding, mindfulness, making guests feel comfortable, trauma-informed training, staff trained in de-escalation and know when and where to refer someone for clinical or additional support, and flexibility for peer workers so they can take time off when needed. And then we had a chat about the physical environment. Identified needs from the people with lived experience were that it was a quiet space that feels safe and warm, options for privacy, a cup of tea and a snack, comfortable space, music and other distractions, that it's a homely, familiar environment rather than clinical. It's a place to decompress where carers are welcome, a physically safe environment, and it also has access to a nice outdoor space. The lived experience, blue sky dreaming, space for activities, separate rooms for private and quiet areas, green, tranquil outdoor space, basic human rights and needs, facilities, and feels like a residential home and not like a health centre. That it's comforting, welcoming environment, low lights, comfortable seating, plants, a sensory area, no obvious branding of an organisation, family-friendly space, pets welcome and potentially a therapy cat or dog that resides there, artwork from people who have visited the centre. They talked about actually allowing the guests of the safe space to actually start creating the artwork. And the health professionals, you'll see lots of alignment there as well. Grass, garden, green spaces, different rooms with options, quiet, low sensory space, space with activities, sensory items available, privacy, greenery and depictions of nature, and enough signage outside for people to find the space. When we look at the topic of accessibility, identified needs from the people with lived experience, something accessible and face-to-face, to know what's going on and how long the wait will be, and information about where to go and where to park. So ideally, people with lived experience would love these spaces to be open 24/7. They do understand that at this point in time, that's not possible with the current funding envelope, but in which case then they'd like it available after hours in late night and early mornings. Potential to increase hours using volunteer peers. So that's something that is up for discussion and needing to have some more discussion, because you'll notice there at the very last point in the health professionals that there was one person who really wasn't a fan of using volunteers. Back to the lived experience people, accessible by public transport, easily contactable by phone, text, email, various other methods, that it has adequate parking, and that it's independent of the existing mental health services. Now, we've actually put that in red because the Brisbane North Primary Health Network has advised us, and everyone was told at the beginning, that these 3 safe space hubs are to be run by the existing mental health hub service providers. But it's important to capture and share what has been said. So with the health professionals, once again, lots of alignment, clear information before attending, hours of operation, what to expect on arrival, ideally 24/7, but at least late afternoon through to early morning, close to transport and parking, taxi vouchers to help people get to and from the space, and that it's open on weekends. In the orange there, the 24-hour phone or email capacity to increase hours while the space is closed. So that was a suggestion that there in orange, so that we can have further discussion about how that might be possible. All right, so it's an enormous amount of information. But what will, as you know, this has been recorded, so you will all be sent the link to this actual webinar recording, so you can re-watch that if you'd like to, and just pause on the slides, as Carrie said, and really take your time. But also you'll be sent the link to the survey, and the slides are embedded in the survey with opportunities for you to comment further. There's free text boxes there and what have you, so you can really, if you've thought of anything else since you're involved in the sessions, by all means, please do the survey, but please, please, please circulate it. We need people with lived experience of suicide in these catchment areas. We need to hear their voices. Other health professionals and stakeholders, we need to hear your voices. So this is the first opportunity for the broader community to get involved in this process. So the survey will be open. Carrie, are you able to actually see the dates there? Oh, it's okay. I've found them here. So the survey will be distributed and available as of this afternoon, and it will close on the 21st of September. So it's the 14th now, so it's open for a week. Then the next thing that happens is, once all that information has been collated, we will then bring the additional information we get from the feedback loop into the combined sessions. So on the 28th of September, there's a combined session for the areas surrounding the Caboolture Hospital and the Prince Charles Hospital. And then on the 30th of September, it's the areas surrounding the Royal Brisbane and Women's Hospital. Following those sessions, then there's another feedback loop, webinar and survey on the 5th and the 7th of October, respectively.
We do have a couple. We have I think a comment, but also a question in chat. So we might just go to that.
Lovely, thank you. All right, so there's just a comment, and it came up while we were talking about the lived experience feedback. So I'm sorry, I'm not sure exactly what you're referring to, but it was a comment around that was overwhelming as a lived experience person, and that when that experience happens with an ED, it gives me even less hope and confidence than I had before. Oh, here we go. Thank you. I was talking about the feelings from the health professionals and how they feel. Okay. All right. So in the 4 locations of Redcliffe region, what is the requirements for this safe space, as there isn't a mental health hub in the region, but there is the Redcliffe and Community Health Hub Centre in Kipparing. Okay. So so we're actually running a separate co-design process for the Redcliffe area, and it's being run separately because there isn't a mental health hub there. So what will come out of that co-design, the PHN will then actually go out to market and look for a service provider and look for a location that then meets the outputs of the co-design process. All right. Well, look, that seems to be all that's in the chat at the moment. Thank you all so very, very much for joining us this afternoon. And we really look forward to seeing all of the survey responses as well. So take care of yourselves this afternoon, and we shall see you soon.
Hi, everyone.